Alrighty, welcome back, Pivotal Discourse fans. I am your host, Jeff Hartney, and I'm sitting down with Dr. Rick Boulay of St. Luke's University Health Network. How are you, Rick?
I am doing great, Jeff. Thanks for having me today.
Thank you for being on the show. So can you tell our listeners what exactly you do for St. Luke's?
You didn't even attempt to say it.
No.
You worked it out before. You were so good. You were so good. Gynecologic Oncology. I'm a gynecologic oncologist, which is a field I never, ever expected to be in and kind of found it by happenstance. But what we treat are women's pelvic cancers. The best part of what we do, though, is we treat our patients throughout their disease illness. So we are trained surgeons, we're trained with chemotherapy, we work with the radiation oncologists, and then we administer all the survivorship follow-up care after that. So we get to really know our patients, and that for me has been a true strength and inspiration. So that's why I love what I do, because of them.
So that's interesting. I mean, I think the field of gynecology is interesting in itself, and then you add oncology. How does one fall into something like that?
For me, it was a complete accident. So we're starting a fellowship at St. Luke's now. So we're training younger gynecologic oncologists. So it'll be the only one in the Valley. There are probably somewhere in the neighborhood of 40 spots, maybe 50 spots per year. So there's not many of us. So how I got and these folks have been doing research in it, and that's what they wanted to do since they were born. And for me, that's not kind of how it went. For me, I finished medical school, and I was really interested in test tube babies. That was the new kind of scientific cool thing back then. And I'm like, this is surgery, and this is medicine, and this is super cool. And it was like someone gets a take-home baby, and it's just like everything great about it. And then, so I went to OBGYN residency to do that. And then my first rotation, and I'm like, nah, I don't like this. So I'm like, that's good. I spent a whole lot of money to go to medical school. I knew exactly what I wanted to do until I looked for the research opportunities in that. And I looked at this big, huge book. It was a folder like that thick, and there were like 100 studies. And I'm like, nope. And I'm like, maybe I'm just in a bad mood. I'll just look at it on Sundays. This is Friday, so I look at it on Sunday. Like, nope. Uh-oh. And then you're like, now what? And I was like, I really liked oncology because it was real surgery and it was real medicine. It was complex, and you got to know your patients, and it just, my grandmother, who was a huge force in my life, had died of colon cancer when I was a kid. And I think it was just all those things coming together. So those people who do it now are on a mission. I stumbled into it, but I stumbled well. I love it. Absolutely love it.
So back up for a second. Med school. Mm-hmm. Where'd you go to med school?
University of Pittsburgh.
Okay. Now, I only play a fake doctor on the internet. So when you go to med school, do you have to kind of have your specialty picked out by the end?
By the end you do, because then you train in your residency. So you spend 4 years in medical school, 4 years in college, 4 years in medical school, and after your first 2 years, it's all the bench clinical stuff, and taking apart dead bodies and putting it back together, and all those things that everyone thinks
fun
about.
stuff.
Like, how did you do that?
I mean, that's why you go to medical school, right?
Exactly.
The cadaver training.
It gives you this sense of the body is nothing but pulleys and levers and pumps, and it loses all its magic. I mean, it's just a series of physics experiments.
I got exceptionally mechanical there.
Yeah, it did. It is. So you learn all that stuff, and then you have to apply that to patients. So your third and fourth years are more your clinical years. So you start to rotate on in your third year on all the major specialties. Pediatrics. Pediatrics was a joy for me.
Yeah.
I got some kind of GI bug twice. I got some kind of upper respiratory bug twice, and I got chickenpox, and it was 6 weeks.
Do you have kids?
Not at that point.
Because I was going to say that's just what they do.
Exactly.
They go to school and they come home with super
Little
viruses.
Petri
Oh
dishes.
my goodness. I have never been more sick when I first had children.
That was it. If you had done a pediatric rotation, that's how it would have been.
Oh.
It was miserable.
Chicken pox too?
Chicken pox, it was great.
Oh.
I was in walk-in clinic. That was really good. And I had helped my friend move the day before, and I was like all achy and stuff. I'm like, oh, I guess I helped him move. Maybe I should have left someone else to get the couch. And so I come home and I'm like, oh, I got an itch. So I looked on my chest and I had like classic chicken pox. And our program director was a pediatric infectious disease guy. And I'm like, I think I have some really bad news for you because I think I infected your entire walk-in clinic today.
No.
So I called him and he goes, come to see me at the hospital. Do not come in the building. Meet me out back. I'm like, this doesn't sound very good.
This is like pre-COVID.
Yeah.
COVID treatment. Get outside. Do not come in.
Exactly.
Stay in your car.
That was the same. Yeah, that's true. It's what we do now. Back then, it seemed very sketchy. So I left my wallet at home. And I did the Superman thing with the shirt and the chest. And he's like, yeah, you have chickenpox. Don't come back until all those crest over. So that was pediatrics. It was the most eventful because we had surgery and medicine and OBGYN and psych. So you just go through all of those. And I put OBGYN last because there was no way in hell I wanted to do that.
Right.
So, and here I am. Spent the last 30 years doing it. So then by then you kind of have an idea of what you're doing and you apply for residency, and the residencies are in your chosen field, but they also have specialties too. Like you can't go right into cardiology. You can't go right into thoracic surgery. You got to do a general fellowship or general residency, and then you do further training and fellowship afterward. So I went to OBGYN to do what the heck's it called? Reproductive endocrinology, and hated it. So I went into gynonc because my assumptions of the things that I wanted were true. It's just the field that I chose, they were not applicable for me. So, and then it was like easy sailing from there. I did 4 years of OBGYN, and I only did 2 years of fellowship. Now they're 3 or 4.
So
and off we go.
You say OBGYN, or were you delivering babies?
I was.
Wow. And then you jumped into the oncology thing. Interesting.
Yeah.
Now, you had mentioned you're also the director of Survivorship. Can we talk a little bit more about that and what exactly that means?
So Survivorship for me is a really interesting thing. And it has a lot to do with my experiences with my family as a kid. Because when I was young and my grandma got a colon cancer, I was probably 13 or so. And there were the whispers in the family. Like you were a kid, so no one talked to you anyway. Right. But when they talk to each other, it's always in the other room, and it's like hushed whispers and that sort of thing. And you see someone you love just really sick, and it was miserable. So this idea of like survivorship and what things look like for the long term wasn't really part of the vocabulary back then. It was like, how are we going to get through the next chemo, and then what do we do when? And the when was when she gets sick enough to pass away. So there was this inherent understanding that you got cancer, and then you got sick from treatment, and then you died. Survivorship comes about because that is usually not the case. In fact, the data show now that you get cancer, you get treatment, and 70% of people are cured. But you wouldn't think that because that's not the language that people use. And when people have completed their treatment, they kind of don't want to talk about it and move on. Yet there's a whole bunch of needs that cancer survivors have. You need to surveil them for their disease that they have, make sure it's not coming back. You need to make sure they don't get other diseases. Like, and the biggest beef I had this year was getting cancer patients, some of them, to take a COVID shot.
Really?
Yeah, you'd think like it would be a no-brainer. I had a patient who went through tedious treatment and died of COVID 6 months later because she never got her shot.
Now, what was the reservation?
Whatever you hear on whatever you hear.
Yeah.
And trying to break through that was incredibly frustrating. Because like, why are you listening to people that you don't know, that don't really have your best interest at heart,
right,
that don't have a clue of what they're talking about. And then you get your doc who's saying, I just got my second booster a couple of days ago. It still didn't hurt. I mean, you get a little ache, but people are like, well, you can get this, and no one's been tested. Like, well, 200 million people got it. So, I mean, like, it's the most tested vaccine ever. At the beginning, it wasn't. So you wait till you go to the end of the line. You wait till, you know, 3-4 months afterward. But it was so frustrating and then people say, well, I don't want to put that in my body. I'm like, you should see what I'm putting in your body. So it just was nonsensical almost at times and incredibly frustrating. But you maintain your composure and you appeal to them in as many ways as you can. And I got many people to take it, but I did lose a couple of patients who didn't get vaccinated.
That's so sad
and
to
it
fight
is
that hard to survive and then to die of something that you could have hopefully prevented.
Yeah. So, and that's the same thing. So why go through treatment for an ovarian cancer if you're going to get breast cancer 15 minutes later? You need your mammograms. So surveillance for other diseases is important too. And looking at, is my patient a smoker? We need to look at lung cancer screening. Do the treatments we cause medical problems like osteoporosis? So you get someone and then they bust a hip and mortality is like 70% the year after busting a hip. So if we can prevent those things, which are part and parcel of generalized medical treatment, but once you get kind of pigeonholed into that cancer pathway, you get that 5 years with your intensive treatment and follow-up, and then like, oh, I guess we got to go do that other stuff now. And by then, people are sick of getting poked and prodded. So survivorship comes about in trying to identify and diagnose and treat the coexisting things that come with a cancer diagnosis, and to promote wellness. And I mean, so the newest toxicity, guess what the newest toxicity is? You'll know when you hear it. Financial toxicity. So this is a new term. So I have a patient, this just happened this week, and it just makes me crazy. You got a patient with a known mutation in her daughter has it, she has it, carries this mutation, a BRCA mutation that caused her ovarian cancer, caused her daughter's breast cancer. She is a great candidate for a new drug, and the vast majority of my patients I can get it for her, but the insurance broker or the insurance company or whatever program that she has will not cover, has a $2,000 out-of-pocket cost per month. So here is a drug that will be very effective for her that I can't get her.
How do you think we get to a point where insurance companies stop price gouging people and start realizing that this is a humanitarian issue and this drug can save somebody's life enough? Like, this is insane.
Yeah, they do. And the insurance companies will tell you, the pharmaceutical companies will tell you they have humanitarian programs and they will give the drug away for free as long as you make under $31,000 a year.
I was going to say, there's a bunch of hoops and everything else that you have to go through. And then a lot of the time you still get denied.
Exactly. So this one is incredibly frustrating for me because this is a drug that can really help someone, and now it's being withheld. And that to me is part of survivorship. How do we get people the stuff they need to stay alive with or without their disease and keep living well throughout that time? So be it financial toxicity, be it emotional toxicity, PTSD that comes from diagnosis and so forth. It can be as big as you want it to be. And that's one of the issues with it. It kind of ends up being the tail that wags the dog. So
now, speaking of the word survivorship, I've heard that some cancer survivors do not like to be called cancer survivors.
Hate it.
Why?
I think, language is a real personal thing. And whether who you choose to read and how the language is used and manipulated, becomes part of who we are. So we recognize words that are difficult or noxious to us, and we recognize words that seem familiar and comfortable. And so a lot of the survivorship community will define survivorship as like, I did a hell of a lot more than just surviving. You kicked my ass. The disease beat me up,
Right.
and I did more than survive. I thrived. So thrive is a common alternative. And some of the cancer battle, lost the battle, fought the battle. These battlefield analogies make people crazy.
Really?
Yeah, because they feel that this is, well, everybody can have different reasons, but the generality is, this is my personal disease and how I choose to manage it. And if I choose not to undergo treatment, did that mean I quote unquote gave up the battle? Or you'll see it in eulogies, and you'll see it in when people do obituaries that lost their battle too, and that just takes all the power away. So there are times when people choose. I've had several patients over the years that said, that's not my thing. I don't want chemo. I don't want radiation. I got a disease. I'm X number of years old. I just don't want to do anything.
Wow.
So you got to go from something is the answer. So that's fine as long as people understand what the benefits and risks of the treatment are, and as long as they're making informed decisions. So my job is always to educate and to help support their decisions, because you can imagine when people make those decisions, sometimes their families aren't the most supportive. And it's my feeling that as long as someone is making a decision for treatment or not out of a knowledge base and their personal values are similar, sometimes you get people who them well enough, and all of a sudden there's a big change, and I'm like last year you wouldn't have thought this way. What changed? So as long as it's in keeping with their personal values, it's all right with me. You do what you want.
So, for lack of a better phrase here, because I know you just said people don't like to hear about the whole battle thing, but do you think we are winning the war against cancer at this point? 20 years ago, if you got diagnosed with cancer, it was kind of a grim outlook. I would say, personally, I've seen an uptick in survivorship in the last 20 years.
So survival has increased about 30%. So
wow.
Over that, 33% since 1991.
Wow.
So the death rate related to cancers has dropped a full third.
And what do you attribute that to? Is it medication? Is it screening? Are we catching it early? That kind of thing? Okay.
All of those things. And also prevention. So getting people not to smoke, getting people to eat well. So here's a fascinating statistic. This one always makes me go, wow. A third of the current cancers that we get, things like colon cancer, breast cancer, endometrial cancer, probably pancreatic cancer, are related to obesity. So if we and another 20% or so, 25% are related to smoking. If we all ate well and put the ashtrays away, 50% less cancer right there.
Oh my gosh, that's incredible.
Isn't that stunning? The things that we do to ourselves.
So obesity, that's interesting, because we just had Dr. Claros on here not too long ago, and we were talking about all the benefits of bariatric surgery. Wow. I knew, everybody knows about
cancer prevention
smoking.
probably didn't come up.
No,
but it is.
Not particularly.
Absolutely. And that's part of survivorship too. I treat patients with endometrial cancer, and they are, one of their big risk factors is obesity. So hooking them up with a weight loss program after we get through the treatment is a big part of recovery for them. And so all my doctor friends are like, so you're going to tell someone they have cancer and then tell them they're fat too? Oh yeah, that's great.
Just
nice
1-2 punch
just tell them
there.
you're ugly too, and then you got all three covered, right? So it's in the delivery. If you say that your risk of cancer coming back is less and your heart attack risk is less and that sort of stuff, and just keep it as a neutral, then you uncover people who are like, yeah, it's about time. I'm there now. So, and then you also uncover people who are like, pass the hoagie, I'm moving on. And I had one of those yesterday. So it's planting the seed. People are going to make the decisions that they make with the information that they have. And not everyone is going to gear toward wellness because it's not the right time.
Yeah.
So, but as long as they know, and as long as they can make that decision knowingly, it's all good.
Have you seen, I mean, as the director of Survivorship, have you seen major lifestyle changes from some folks? Like I know, unfortunately, we lost my stepfather about 11 years ago to liver cancer. Thank you, by the way. And he, you know, he put up a heck of a fight, and we were doing all sorts of experimental things. He did some type of sand blasting type deal. It was like brand new. Unfortunately, he, you know, didn't make it, but I've noticed a shift in my mom where the two of them like to travel a lot together, and I've noticed that she really has taken on this, like, you know, flag for him, and like she wants to go to all the places that they haven't gone to. As a matter of fact, she I feel like it was like a month after he passed, she went on this like African safari, which you know, if you know her, she would not have done that having not gone through that. So I just think that cancer in itself not only can change the person who's going through it, but also their loved ones as well.
Absolutely. That is such a beautiful and loving tribute to someone. That's thank you for telling me that story.
Yeah.
Yeah, you see it in a couple of ways. Oftentimes, you'll hear about the battle against time, to use the battlefield analogy.
I know,
but
it's hard not to do it.
It is. But this sense that the clock is just spinning, and you have so much to do and perceived so little time. So a lot of time there's this urgency, and the urgency can spin out of control and cause a lot of anxiety and things like that, or it can, if it's controlled and positive, it can be what your stepmom did.
Or my mom.
What your mom did. Yeah. And use it to honor someone. And that's just like the most beautiful thing I've heard in a long time. That's great.
She's incredible. We actually hiked to Machu Picchu together.
Wow.
We took his ashes with us, and, you know, all the great spots along the trail, we put a little spot to him, and it's incredible. So like everywhere she goes, she kind of takes a little piece of him with him, or with her, and
so he's been there with her.
Yeah, and he gets to see some of the best sunrises and sunsets, you know, all throughout the world. It's pretty remarkable.
So with survivorship, oftentimes generationally, so you'll have folks doing things for their kids or doing things for their grandkids. Or if the kid's the one with the cancer, moms and grandparents doing everything they can to support that journey and make it as palatable as they can. So you're absolutely right. Cancer does not affect a person. It affects, at the very least, a family. And how you define families, whether it's close friends or whatever, it affects a whole bunch of people.
Well, it's interesting. You mentioned time, and I constantly beat my kids over the head. Not really. I mean, but I tell them.
We'll edit that out.
Yes, I tell them about time and how it is the greatest commodity that we have.
Greatest gift we have.
And you know, I say this to my wife all the time, because it's always about, you know, money management and how you grow up thinking that you're supposed to save for retirement. I don't want to do that. I've lost enough people in my life, whether it be through cancer or whatever, that tomorrow's not guaranteed. So, you know, I'm not going to be irresponsible, but at the same time, like, I want to experience stuff now. And I think everybody needs to kind of take that.
It's so true. And I think, as you say, you can't be irresponsible, but like, what you waiting for? And this was a great example for us personally. So my wife was diagnosed with leukemia when we were about 44.
Oh, geez.
So it was like, she's great now. It's 15 years. She's doing great.
Okay, good.
There was literally, so sometimes we tend to be workaholics.
No.
No. Sometimes we're working hard and we just like don't make time to break away.
I don't know what that's like.
So there was literally on the coffee table a brochure for a a cruise, a clipper ship cruise that my wife had wanted to go on for 8 years. It was.
Is your wife a doctor as well?
No.
Okay.
So it was there, and I don't know. I'm like, oh, this is really nice pictures. That would be fun. We should do it. It's like, yeah, we should do it. So anyway, we did 3 of them, like in the first 3 years after.
Excellent.
It was because, just as you described, you find that time is so precious.
It is.
And your ability to use it well. I mean, we use time so poorly. I mean, we spend our time in work, we spend our time doing stuff, and then developing those relationships and just spending time being and doing nothing is something that Americans are really lousy at.
I don't think people understand that time management is probably one of the greatest skills. If you can master time management, you're light years ahead of most people.
Exactly. Yeah. And I spend too much time doing things and rather than just being me. So I have to learn that lesson again. But it was a real urgency that I felt, that we had to live fast. We had to do the things that we really wanted to and do the things that were important. And also for people who have, like, I got a lot of weird gifts. Like I'm a doc and I have a classical singing background and I write and publish stuff. And I'm like, I got to get all this stuff out. And at the time I started writing because it was a good way for me to manage the emotion and how to put it, and I just found lessons absolutely everywhere, and I just wrote them for me. I had no intention of publishing them; they were all prose. And then I'm like, maybe I'll send one to JAMA, and it was it was the first one I sent, and JAMA's like really hard to get into, and they accepted it. I'm like, what? So then I'm like, I have these like a bunch of other ones here. I'll just start sending them out, and everyone started accepting them and publishing them. And they were lessons that I learned from patients. They were lessons that I learned from my experience with cancers. They're all cancer related. But I just like had this burning urge to kind of get this stuff out and share it. And I had the same with music. I've found that with me, music became this like conduit of learning. And there were songs that I heard forever, and all of a sudden I heard them differently. The lyric just meant so much more. I just remember in bed, like grieving as all these horrible things were happening, listening to the same song over and over again, going, wow, that is the most, whoever thought Bridge Over Troubled Water was so powerful? And I'm like, it's just a song. Spam risk. I don't have to. Do I have to answer that one?
No, that's up to you.
Right,
I mean,
okay.
It's a risk if you answer it. But it's interesting that you talk about music because literally the same thing happened to me when my stepfather passed. Now, I am the type of person that I can't hear lyrics. I don't understand it. My brain just doesn't work that way. So if it has an awesome hook, I mean, it could literally be a song about, like, I don't know, something horrible, and I would think, oh my gosh, that song's amazing. And they're like, Jeff, do you not know what that song's about? I'm like, no, of course I don't. It just has an awesome hook. But when my stepfather passed, all of a sudden something shifted, and I could start to hear certain lyrics of certain songs. Bridge Over Troubled Water is a perfect example.
Over the Rainbow. Oh my God. I couldn't get through that song for like 2 years.
Like, he speaks to me through music, and it's odd, and I don't know if, like, maybe I lost a screw or something, but it's interesting, and my mom has a similar gift as well with music. So
then I started harnessing all those things to cancer survivorships and the lessons that we learned, because it's so hard to talk about. You know, I saw this thing like a few years ago that was like, well, at the next Thanksgiving, it was before the pandemic, at the next Thanksgiving, when everyone's together, why don't you talk about your wishes when you're at the end of your life? I'm like, that is going to be one freaking really fun Thanksgiving. So, like, oh, by the way, pass the yams. I want to be buried. You know, but it just brought up to me the same, like, how do you have these discussions? How do you learn from each other? There are support groups that people can go to and survivors can go to and family members can go to, but they are support groups, and they're formal and they're uncomfortable, and there are some people who want to talk and some people don't, and it can be a little awkward. So I'm like, let's put music together. So we ended up writing a whole album about some of the topics of survivorship, and I have thousands of them. I just have no time to. I put one together that we recorded.
Now, what type of music?
That was
like folk.
I have a
folk song?
No. I have a voice like Josh Groban, so it's kind of like classical crossover type stuff.
Okay.
So now, now I do more jazz stuff. I've been working at kind of toning that back a little bit.
Okay.
I took the pandemic and I learned 200 new jazz songs.
Yeah, don't think I'm going to let you get away with this, because when I was doing my research for this interview, I'm trying to figure out who I'm going to be speaking with, and then I'm like, oh my gosh, it's the singing doctor, which you became famous to me during the pandemic because they kept putting up the videos of you scrubbing your hands and you just rip out this opera.
Yeah, that was a classic. They were like, all right, do you need to do like a 15-second or 20-second thing on hand washing, and just pick a few songs that you want to do? And I'm like, all right, how about Chandelier? And they're like, yeah, probably not that one. But so, I did that one. There was like between cases on a Friday afternoon at lunchtime.
So did you go to school for it?
No, I went to school for music. I went to school for medicine.
Well, I know that, but was there a minor? Were you in the choir there? Like how? No, you don't just get a voice like that without some type of training.
So I sang when I was a kid, and then I stopped when I was in medical school.
Gee, I wonder why.
It's a little busy.
You act like it's tough to do. Medical school.
No one wants to hear you belting out anything in a little apartment.
Working on your cadaver.
Shut it down. Exactly.
Not to take that lightly, of course. We're very serious.
The morning and the cadaver's got his fingers in his ears.
Jeez.
Yeah, no. So I gave it up for a long time. So medical school, and then residency, and then fellowship, and then we had kids and that sort of stuff. And then like around 40 or so, I'm like, I used to be able to do this. Maybe I should try and take lessons, because I was singing, and I started singing back at our church back then. I'm like, I can still do this a little bit. So I found a teacher at Muhlenberg College who was an opera singer, and it was the first time I ever took formal lessons, and it was with a guy. So it was interesting, because every time I'd ever sung before, who was instructor was women, and it was just finding a tenor who could sing like that, and then all of a sudden found it in me. It was weird. I never knew I could sing that stuff till I worked with him. I found a whole octave. Now I have a 3-octave range, and which is ridiculous, but I never even knew I had those top notes until we were singing one day. He goes, That's the best B flat I've heard in this room in a long time, in his practice room. I'm like, what do you mean B flat? I'm a baritone. And he goes, no, that was plays it on the piano. I'm like, oh shit, I didn't know I could sing up there. And I've performed like high E flats, which is just crazy Michael Jackson high notes that I never knew I had.
Well, an opera is very different than say show tunes.
Well, sometimes. If you look at West Side Story, that's like kind of operatic.
I can't stand that show.
Oh, really? I love that. That's one of my favorites.
Although I will say the Spielberg.
Didn't love it.
I actually thought it was okay. From a filmmaking perspective.
From a filmmaking, it was beautiful.
Unbelievable.
Yeah.
I still hate the story. I could care less about the story.
Oh, really?
Yes. It's so overdone.
You know he dies at the end.
Yes, I know.
Okay. I like, it seems so inverted, because usually they end on this big happy note. And with Act 1, so the structure of it is so freaking cool. So Act 1, that ends with all the songs that they sang in the first one come together in one song. That's like structurally unbelievable.
See, but again, I'm the same guy who argued in film school that Die Hard was better than Citizen Kane. So I was kind of booed out of the room on that one too.
Citizen Kane was kind of cool. Die Hard's kind of cool too.
Citizen Kane was cool for
structure
and what it did for the time. There was camera movements and things that nobody had ever seen before. Yeah. But story-wise, come on. Anyway, we totally digressed.
I don't know what we're talking about anymore.
So let's get back to the singing.
Oh.
So you were...
So I started again, and when I was 40, so much is tied up with my grandmother. We used to sing together. She got me my first guitar. I was probably like, 4, and a little keyboard thing. And I just gravitated, and I could make music. It just, whatever it was in me that I had, that I could do that. And I just played by ear. So then learned, and we sang together. We sang together at midnight mass on Christmas Eve. That was really fun one year. And then I still do that. So it's nice to think about her. And last time I was supposed to do "Oh Holy Night," which is one of my favorite ones for New Year's Eve, or Christmas Eve. And I got vertigo, and like I really got vertigo. I got it for like 2 weeks, but it just came out of the blue. I was fine. I took a nap on New Year's Eve. I woke up. I'm like, damn, I can't even walk. So I ended up calling the choir director, and I'm like, you know that fall on your knees part?
Maybe doing that for real. Yeah. Can I just start it from the floor?
My daughter, who's going to opera school now, took my place. So
that's cool.
Yeah, she's the one that sang with me when we did the prayer. I don't know if you saw that.
Oh, yes. Okay.
That was her. That was one of the funniest things. She only will sing classical, so she had to sing the pop part of that, and she did not want to do it. And she also has a super high voice, and that was a low part in her range, and she didn't know it. So that was a Sunday. So I said, "Do you want to just do this?" And she's like, "No." I'm like, "All right. You want to think about it?" "No."
Well, I'm just going to hit record here, and maybe you'll do it.
So that was like noontime. So later in the day, I'm like, "So really, do you know?" And she's like, "All right, if you have to, Dad, but I don't sing popular stuff anymore." So
that's okay. And
action. So yeah, set up the iPhone, turned on the thing, and she sang her part, and I sang mine. She had her music. I had done it before.
And that turned out wildly popular.
It turned out there was like 50,000 views. So it was.
As a person who makes videos for a living, it drives me crazy.
That we can
50,000 views, no big deal.
On Sunday night.
Yep, just crank it out.
10 o'clock.
Meanwhile, I spend 20 hours editing something, and it gets like 130 views. Thank you, Dr. Rick.
It took us 4 times.
Oh,
and it
4 times?
It
really?
took us 4 times because she kept messing up the end, which I have to hold this super high note really quiet, and she would like mess up the end. And I'm like, really? We got all the way through it.
I love how you're throwing your daughter under the bus.
She should hear it now. We
did it 4 times, and it was all her fault.
It was all her fault. She'd learned it an hour before, though, in her defense. So the last time we got it, and then that's why the video ends with, "We got the end."
But nobody saw the other takes. It was just that one.
No, they're still in my phone somewhere.
Now,
I probably deleted them.
Do you use your music to help your patients?
Yeah. So with all this stuff, all this writing and music and stuff that I started to do, I'm like, how can I broach these topics that I couldn't broach as a kid because no one would talk to me about them, didn't know what was going on with my grandmother's cancer, and now it's 20 years later, and my wife gets a cancer, and like we're in the same thing, and treating these patients, and no one wants to talk about it. Like they still whisper the word cancer.
Well, it's kind of like Voldemort. Nobody wants to say
exactly. It who can't be named.
Yes, correct.
Exactly. So it just defines the level of discomfort with the word alone, let alone the entire process. So I'm like, how can I because I'll have people who figure out like really cool ways of managing certain things. I'm like, how can I get your knowledge to yours? I don't know. Why don't you want to write something up for me? People do not like to write.
No,
so
I hate to write, and it's part of my job.
So I'm like, I enjoy writing, and then I edit it, and then I get something at the end, and I'm proud of it, and like people just do not like to do that. I found I do my best writing at 4 a.m. when I'm just can't sleep, and I'm like, I got to get this out. So we tried that. It didn't work. I started a not-for-profit and started a whole online writing thing and wrote most of them. And then people who wrote a few of them, I edited and put it on. And then that's about as far as it went because no one wanted to write and share stuff.
Okay.
So then I figured, all right, let's do it with music. And because I just had those memories of being alone in bed, listening to the same song over and over and learning from it. And saying, well, why don't we try that? So I've actually recorded 4 CDs. The first one I did with the Kutztown Jazz Group, the Kutztown University Jazz Group, because a friend of mine was on staff there whose wife was a patient. And I'm like, I got this idea. He's like, oh, that's a cool idea. Let's try and do it. So we did. And then that turned into concerts. And I haven't been able to do them during the pandemic, but we would do, these were the coolest things. It was like kind of pick 10 topics. So you got 2 hours. So you got 5 topics a half. And I would start with a question that I posed to the audience, and I'd give everyone clickers. And the question was, what do you like the word survivor? And we're just talking about that. So while they were voting, there was like a couple minute lag for everyone to vote and for it to tabulate. And then in real time, we'd get it a couple minutes later. And I'm like, perfect time for a song. So let me sing Eye of the Tiger by Survivor, like that sort of thing, like do something tangentially related or something with a message, and then talk about my experiences with it, and then do audience participation and open it up to whoever wants to talk.
Oh, that's cool.
It was so cool. I learned so much in those. It was just a giant therapy session. It was more than learning from each other. It was more than supporting each other. It was entertainment. It was just like really super fun, and people just really, really enjoyed it and got a lot out of it, and so did I. And then the pandemic came.
Are you going to start them back up again?
Probably.
That's
so
cool.
I just want to, one of the issues is bringing people who are immunocompromised into one big room during a pandemic.
Yeah.
Sounds like a recipe for disaster.
Yeah, I don't think you want your name attached to something like that.
I think that would be very bad.
Unless you go work for another health network, but not this one.
We will not do that here. We
right.
do smart and kind things here.
That's correct.
We do very kind things here.
Yeah.
This is a beautiful place to be.
Yeah. All right. So let's transition here and let's talk about the future of cancer. Is it looking bleak, or are we looking...
Well, if we look at that data that we talked about, so you can see this data on cancer.org, the American Cancer Society's webpage. Maybe I'm the only one there looking at it, but every year they publish a cancer statistics, which I find really cool.
Well, and you're a cancer doctor. Just throwing that out there. I might not find it that interesting, but
I love graphs. I love like charts and graphs and stuff.
Okay.
So if you look at it, and it has the number of cancer diagnoses and the number of cancer deaths by disease site, by gender, by year since 1930. So you see this like huge rise after we talked about smoking, after people started smoking, and then you start to see the cancers come out, the lung cancers and the deaths from it. And it's really interesting because you see the men's curve go up first, and then you see the women's curve follow, because about 10 years, because it was just not a cool thing for women to smoke. It was all the James Dean types.
Right.
And like, Elizabeth Taylor wasn't smoking back then. But then they got those like, long cigarette holders. Then it became sexy for women to smoke too, until Brooke Shields put them in her ears. And then when she put them in her ears, then you see the incidence of smoking come down, and you see the cancers follow. It's so you can see these trends, what was happening in society and what shifted these diagnoses and things like that. But starting in 1991, so President Nixon in 1974 started what we now know as the National Cancer Institute and the cancer centers that are across the country that are coordinating and spearheading research and treatment for cancers. And the country was like, we gave you this much money in 1974, and by 1984, you've done nothing.
Right. Like
the cancers are only getting worse, and the death rate's getting worse. And then by 1990, the same. Like, you guys don't know what the hell you're doing. And maybe. Because I think we're just getting it now. So cancer is not one disease.
Yeah.
So when you think of hypertension, high blood pressure, that's not one disease either. So it's similarly, cancer isn't. So one treatment for it, and how many high blood pressure medicines do we have? And so cancer is the final manifestation of a cell that's gone corrupt, and it can be just like people. It can be corrupted in so many different ways.
This may be a stupid question, but cancer kind of like a virus where it constantly evolves?
Yes.
And so like you treat it with one treatment and then it's just like, all right, I had enough of this. I'm going to evolve.
Yeah, exactly. And that's one of the biggest problems we have with some of the cancers is that it finds a way around our treatment because it's evolutionary. So you kill everything you can with whatever drug or modality that you have, and then the ones that aren't killed from it have developed or you've identified a portion of those cells that have an intrinsic ability to get around your treatment mechanism. So they're not cohesive or not a population of cells that are exactly the same. They're DNA. So once our DNA changes, and the cause of cancers is the fact that our cells are growing uncontrolled, and the reason for that is the control mechanisms within the DNA are corrupted over time from genetic stuff that you were born with, from exposure to chemicals and sunlight and radiation and that sort of stuff, and some that we don't even get. Obesity, smoking, all the stuff that we talked about. So as these change, we can see the gene abnormalities that happen, and we're probably talking. So we got 30,000 genes in humans that are making stuff and allowing you to function the way you function. So we're talking about understanding maybe about 200 of them. So we're just at and this stuff's all new. So this is probably the Human Genome Project. When we first sequenced the entire human genome was 2001 or 2000, I believe. So we're talking 20 years of knowledge of these genes and how they interact and how they work with each other, how they compete against each other, how there are workarounds in them, and tracking them down, stumbling upon some. And as we've done all this since 1991, in addition to the regular chemotherapy and radiation and surgery that we had done before, and early diagnosis, we've begun to see that trend of cancer deaths go down. Surprisingly, the trend of cancer incidence or new cancers is still going up. Mm-hmm. So if we just get everyone to eat better and stop smoking, we'll be a heck of a lot better than we are now. But we are now doing better with all of those cancers. So is there reason for hope? Absolutely. Despite the horrible things that we do to ourselves, there is a reason for hope because we're finally beginning to understand the basis of these diseases that we call cancer. And not only do we understand them, we are identifying what we call actionable mutations or abnormalities in the DNA that we have drugs that can repair those. And if we don't have drugs that can repair them, sometimes we can make genes better and supply them. So we're starting to do that in things like sickle cell disease, and we're starting to see that happen now too. We're starting to activate the immune system in ways that we've never have before. So when we look at cancer survival curves, we're talking who got the disease and who's alive at 5 years is kind of what we do. So many of these drugs are so new that the last 5 years and the next 5 years are going to be completely different.
Interesting.
So I always caution patients when they ask, well, what's my 5-year survival? What's my cure rate? So it's like doctors never say cure, and then like, yeah, we know you guys don't. I'm like, no, we just don't. That's a human word. It's not a doctor word. The doctor word is 5-year survival because we stopped measuring at 5 years. Okay. So you tell them that, and I had a discussion with a 42-year-old yesterday. That's the very same thing, and the tears start coming. I'm like, but that was the last 5 years. The stuff that we're doing for you is the next 5, and I can't tell you what it's going to be, but it's going to be better than that. Yeah. And then I always tell patients, the longer you're here, the longer you're here. So if we get to the next level of understanding and new drugs and new ways of approaching this, then if people are here longer, they can take advantage of those. And then the idea, I have a patient now who was diagnosed with an advanced ovarian cancer in 2007, I want to say. Maybe 2004, a long time ago. Well, it was 2007. And she has a BRCA mutation. So BRCA was defined in breast cancer, but it's also active in ovarian cancer. And we've had drugs that have been helpful for them, But ovarian cancer patients are so rare, to get them in trials was really hard. So it took for this patient until 2015 and when it was actually available to her. She's taken that, and she was on chemotherapy every year for the first 7 years. So yeah, it was 2007 to 2015.
That's a long
So she'd be
road.
on for 6 months and then off for 6 months, and the disease would recur. On for 6 months, off for 6 months. And she went on this drug, and she's never been on anything since.
No kidding.
It's been since 2015, and it's so another 7 years. She takes one pill a day.
Wow.
So it's that we will understand that, and then the philosophies of cancer treatment are changing too. We used to think that we used to have to take out everything that cancer touched, or and do these big, huge, deforming surgeries like radical mastectomies. Like, you don't do those anymore because the disease is systemic. It gets in lymph nodes, it's in other places. You have to treat systemically. So now we just do a little lumpectomy and then some radiation around it. So it's, as we understand how the disease is, we treat it, and we can improve quality of life, which is huge, as well as improving survival too. So the next, and then we're going to have to improve survivorship, because as we see how these are all related, not only does the disease cause problems, but treatment can cause problems. And then they may have genes that predispose to one cancer that they may have that may predispose to others. So figuring out how these all fit in and how to keep people well is going to be important for the next 10 years, but we are definitely going to do better, and things are going to change. It's, when we used to treat ovarian cancer probably until the mid-teens, we used to start with a big surgery, and not everyone could get through it. And
Sure.
People end up with colostomies and just sick, and then you have to put them on chemo afterward. Now we start with the chemo, shrink it down, and then do a surgery to get the rest of it, and the surgery is much less morbid. The side effects, complication rates are significantly lower, and they do much better, and the cure rate's the same. So yeah, the important thing though is clinical trials, and when patients allow themselves to participate in clinical trials, it's good for everybody, but it's oftentimes good for them as well.
Sure.
So I have a lot of respect for people who choose to do that.
So one of the most fascinating things that I think that I've gotten from our conversation today is the whole obesity and cancer thing. And we know.
Before you go, I was on Weight Watchers in January. I only lost 6 pounds, so I quit. If you're going there.
No.
Oh,
no,
okay.
No. Not quite. Not quite. It was Noom, please. No. But I think it's been ingrained in our brains that smoking causes cancer. Mm-hmm. How do we now flip the script and get that same marketing message out to the masses? Obesity causes cancer. Because I think if you do that, you will see a significant drop off.
I don't know. It's a really touchy subject to discuss because, look at Lizzo, who's made a career of being a big woman and being okay with it.
True.
Right?
True.
So I think what society expects of people and what people expect of themselves doesn't have to intersect. So whether you choose to be okay with your obesity and live your life well with that, that's great. But understand the ramifications of that. Understand the hip replacements and the knee replacements and the diabetes and the heart disease and the cancers that come along with that. So I don't know. In my mind, seeing folks on dialysis related to diabetes and stuff like, if that doesn't change their mind, I don't know that this stuff will. So I think we have to, as society, come together with the fact that there are healthful ways to live and there are not healthful ways to live. Each of them has their ramifications. People can choose to live the way they want, but understand the choice that they're making. And that has nothing to do with who they think they are or who, are you going to respect someone differently because they're heavy or not heavy? No, they're the same person. It's just weight related issue. But if we say, then that's okay, you just be you, then are we tacitly giving permission for folks not to accept the fact that their unhealthy choices are making them unwell as time goes on. So I think it's a tricky situation. I think our society is trying to come to grips with its diversity, and trying to come to some understanding that when all is said and done, we're all the same, and we should be respectful of everyone's choices. On the other hand,
but don't you think there's like a finite thing to cancer? Like you say, obesity causes, hip replacements and diabetes and things like that. Well, people can live with a hip replacement. They can live with diabetes. Mm-hmm. When you get that cancer diagnosis,
we just talked about that. You can live with cancer.
I know you can. I'm not trying to shoot you in the foot here, but
ouch, you did.
But I just feel
no,
like,
I know what you're saying.
Know what I'm saying?
Yeah. So then that becomes, do we kind of utilize the hysteria? That's probably a bad word, but utilize the bad cancer press of and kind of use that to help us get to our aim of a lower cancer society. I think people just need to know. I don't think they know. I think that's
more what I'm trying to say.
Exactly. So and as physicians, like I said, even as we are trying to deal with how do we bring these things up to patients, because they'll say, yeah, I know I'm fat, I get that, but it's just something I can't deal with now. Yeah. And I think that has to be respected. Again, as long as people are aware of the connection, and maybe you've just been through treatment, maybe you don't deal with it this year, maybe you deal with it next year, and it's a hard thing, much like smoking and alcohol. There's society expectations and family expectations of what's normal, and if you're supposed to clean your plate and that's what you do forever, or if someone smokes a cigarette after dinner and that's what everybody does. So just as cancers don't hit families, cancers don't hit people, they hit and affect families. I think these societal vices and things are similar, and I think we're afraid to call them out now because we don't want to offend people. But I don't think we need to talk about offending people. I think we just need to educate and allow people to make their choices being well educated.
No, I hear what you're saying.
It's hard.
I think all I was trying to say was...
You were calling me fat.
I was not. I was not. I would never call anyone fat.
I think we all heard you.
At any rate... Folks, please know that obesity can cause cancer. That's all I'm saying.
Yeah,
right.
It is a huge lesson. Well, it is a big lesson, and I don't think we talk about it enough.
So, last question.
Yep.
Do you have any advice for our listeners who may have recently been diagnosed with cancer, or family members of somebody who's been diagnosed? Mm-hmm. Like, what can you? Do you have any help for them?
Yes, I think. Well, I'm the only one in my family without cancer, so I guess you're asking the wrong guy. It seems like the lightning bolt has hit so many times and I was just fast enough to miss it. But the lessons that I have learned are, the first thing is take a breath. Yeah. This is a marathon, not a sprint, blah, 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 all those kind of euphemisms that you use. But this is a new way of thinking. It's wise for you to not let your mind go a million miles an hour and give it a chance to rest and settle with what your goals are.
That can be easier said than done.
It is hugely easier said than done. But I think it's a big reminder for folks that they don't have to answer all the questions the first day. They don't have to get all their questions answered the first day. They don't have to do all their research in one day. So I think the first thing to do is let it settle, and then start your journey. That's another word that makes cancer people crazy sometimes, journey. I think it's a great word for it, because in my mind, a journey is like you're going somewhere, not quite sure where you're going, not quite sure how to get there. There are twists and turns along the way, and you may be expected to deal with the twists and turns. And I think it's a great analogy for cancers. The other thing that I tell folks is when cancer zigs, allow yourself to zag. We're going to create a plan. We're going to get from here to here, but there's going to be not necessarily a straight line. And if you anticipate that there's going to be a straight line and it's going to go straight from here to there without any variance, then as soon as there is variance, it feels like it's wrong. So everybody's journey is personal. And how they choose to go about it, how their disease allows them to go about it, how they respond to treatment is individual. So, we set a plan, but give room for wiggle room, and don't feel that it's wrong if that happens. It's just we're setting new goals, setting new plans. And I think that, again, gets your mind off of, we have to get to here, we have to get to here. No, we have to get to tomorrow. And then we have to get to the next day. And then, that there's like, when you start to think about cancer, all those stupid like proverbs like mean so much. Like the journey of a million miles begins, or 1,000 miles begins with a single footstep. This is exactly when that is. And it sounds so petty until you're there.
Yeah.
And then you're like, oh, that's what this means. So those are two good ones. What I really encourage patients to do is to educate themselves, and to find people who've been through their disease, who are willing to share their experiences with them, and find online.
I would say with a caveat, educate yourself the appropriate way. Don't just jump on the internet. You could learn a bunch of things that aren't necessarily accurate.
Yeah. So start with sites that are familiar. Start with the American Cancer Society. Start with the National Cancer Institute. And they have sites that they reference. Go to those. Go to the site of your disease, Pancreatic Cancer Society, that sort of stuff that you can then get a footing under yourself. And then when you venture into the bullshit ones, sometimes you can feel it.
Okay.
So like with crazy promises and stuff like that. Not that, again, that we know everything, and not that everything outside Western medicine is wrong. Certainly not. I have a patient now who has a recurrent ovarian cancer who treated with homeopathic treatments, and which is non-Western medicine based. It was dietary changes and enemas and all. She continues to go through a whole lot. And I treated her, I measured her tumor marker, her blood work, like she was on chemotherapy. And damn if it didn't respond. When she made changes, I could see the numbers change. And I'm like, well, here I am learning something from you. So I think that's the message to doctors. So
Sure.
I think as physicians, any healthcare people, I think we have to be careful in use of evidence-based medicine. And that's where we need to start. But I think there is room. Oh my God! Don't take away my license.
No, keep going. Go ahead.
I think
Everybody
there is
needs
room
to
for
hear
alternatives, and because we don't have all the answers, I think that is remarkably egocentric to assume that we are the only ones who know it. You look at Chinese medicine, which is and Eastern medicines that have been going on for years and years, like millennia, and it's exactly opposite of what we do. They'll do a little bit of this, a little bit of that, and they're all, natural substances for the most part. And it's how they all work together, whereas what we do is synthesize one compound,
Right.
And maybe add another synthesized compound with it. And so it's very fine and precise and measurable. And theirs is not.
But I think it goes back to your zig and zag analogy, where at the end of the day, you're just trying to find the best combination for healing.
Right. Exactly.
Whatever that may be.
Exactly. Yeah. And because I've had patients that say, well, my other doctor said I shouldn't do this. And I'm like, well, if you're going to do it, let's at least be honest about it, and let's tell me about it. And I can look it up and see if there's any, safety issues with it. And if there aren't, what the heck?
Or you could always respond, does your other doctor sing? Because I
Let's
do.
hear
and
him
I can
do
hit a B
Nessun
flat,
Dorma.
so... Right.
At the scrub sink.
I'm just kidding. Not to make light of it. But anything else you'd like to tell our listeners?
get their posse together.
Mm.
So that's another big. You can't do this alone. You need, and it's not always the people you think you need. You need folks around you. Yeah. So they'll be, and also trust that your posse has your best interest at heart, but they may not always say it right. Like there's always someone who's going to say, "Oh, I know someone who got that cancer and they died back." Don't say shit like that.
Yeah, exactly.
Come on.
Thank you.
That is helpful.
Let's get on team positivity here. Come on.
So you have to understand that someone's going to say something stupid, but that's part of it, because they're maybe learning too, and they may be learning that like how important language is and what are sensitive topics and what aren't. But they're going to be there for you. So and accept the help. That's what, so many people have been, well, I'm usually helping people. I'm usually not. Well, so my response to that is, the joy you get from helping people and helping them through that. Yeah. Well, let someone else have that joy.
Yeah.
Don't take that away from them.
Yeah.
So those are all the big things, I think. Zig and zag, get your posse, pause or breathe, and educate yourself. I think with all that, get a team that you trust too, a medical team.
Oh, yeah.
There are so many people who have said, I've heard, like, so-and-so has a horrible bedside manner, but they did this great job. I'm like, well, there are people that can do both for you, really. You don't have to put up with someone.
It's like one or the other here.
Exactly. They're not mutually exclusive, and all people who can operate don't have to be jerks. And so find a place that you feel like you can trust the folks to work with and be interactive with them.
So I would be remiss if I allowed you to leave here without giving our listeners a little taste of that sultry voice of yours.
I don't know if we're going to do this.
I think you can. There's a microphone right in front of you.
But
cameras are rolling.
All right. How about Over the Rainbow?
Ooh.
So how much do you want? Like 20 seconds?
Yeah, a couple.
Okay.
Real quick.
Okay. I'll just do the first verse. Oh, you're going to make me do this. Somewhere over the rainbow, way up high, there's a land that I heard of once in a lullaby. How's that?
Excellent. Dr. Rick Boulay, St. Luke's University Health Network, thank you so much for coming on the show.
Thanks, Jeff, for having me.